If your eye doctor told you that you just have dry eyes, stop. Because what I'm about to share could mean the difference between treating a surface symptom and catching a potentially life-altering autoimmune disease. Millions of people walking around right now with a dry eye diagnosis are actually living with Sjogren's syndrome, and they have absolutely no idea. Today on Active Healthcare, we're breaking down the dangerous difference most people miss, and by the end of this video, you'll know exactly what warning signs to watch for and the right questions to ask your doctor. The average person waits nearly 3 years before getting the correct diagnosis. 3 years of the wrong treatment. 3 years of a disease quietly doing damage that goes far beyond your eyes. So, if you've been struggling with dry eye symptoms that just won't respond to drops, or if something in your gut is telling you there's more to the story, keep watching. This one is for you. Let's start with the basics. What exactly is dry eye disease? Dry eye disease, often abbreviated as DEAD, is a condition where your eyes either don't produce enough tears or the tears they do produce evaporate too quickly. It sounds simple, and often it is. There are 2 primary types. The first is evaporative dry eye, which is by far the most common. This happens when your meibomian glands, tiny oil-producing glands along your eyelids, become blocked or dysfunctional. Without enough oil in your tear film, your tears evaporate before they can properly coat and protect your eye surface. The second type is aqueous deficient dry eye. In this case, the lacrimal glands simply aren't making enough of the watery component of your tears. Both types result in similar symptoms: a burning or stinging sensation, grittiness that feels like sand in your eyes, redness, light sensitivity, blurred vision that comes and goes, and here's the paradoxical one that surprises a lot of people: excessive watering. Your eyes produce reflex tears when the surface is irritated, which can actually make you cry more even though your baseline tear quality is poor. The causes of dry eye disease are wide-ranging. Prolonged screen time. Environmental factors like dry air, wind, and smoke. Contact lens wear. LASIK surgery. Aging. Hormonal changes. And a long list of medications, including antihistamines, antidepressants, and blood pressure drugs. In the United States alone, an estimated 16 million people have been diagnosed with dry eye disease. It is genuinely common, and for many of those people, it is exactly what the doctor said: it is a local, mechanical, or environmental problem with their eye. But for a significant number of them, it is something else entirely. Which brings us to Sjogren's syndrome. This is where things get critically important. Sjogren's syndrome, spelled S-J-O-G-R-E-N-S, is a chronic systemic autoimmune disease. Let me emphasize that word, systemic. This is not an eye disease. It is a whole body disease that happens to attack the eyes among many other things. In Sjogren's, your immune system loses the ability to distinguish between foreign invaders and your own tissue. It begins attacking your moisture-producing glands, primarily the lacrimal glands that make tears and the salivary glands that make saliva. But it doesn't stop there. Over time, Sjogren's can involve the joints, the nervous system, the kidneys, the lungs, the skin, and more. There are 2 forms. Primary Sjogren's occurs on its own, with no other autoimmune condition present. Secondary Sjogren's develops alongside another autoimmune disease, most commonly rheumatoid arthritis, lupus, or scleroderma. In terms of who gets it, approximately 90% of diagnosed patients are women. The typical age of diagnosis falls between 40 and 60 years old, though it can affect men, younger adults, and even children. It is considered one of the most prevalent autoimmune diseases in the world, affecting an estimated 4 million Americans. Yet despite that prevalence, it is consistently under-recognized. The Sjogren's Foundation reports that the average diagnostic delay is 2.8 years. Nearly 3 years of living with a serious autoimmune condition while being told your only problem is dry eyes. That gap is not just frustrating. For some patients, it is dangerous. Now here is the core of the problem. Why do dry eye disease and Sjogren's syndrome get confused so often? Because on the surface, literally on the surface of your eye, they look identical. Both conditions cause dry, burning, irritated eyes. Both reduce tear production. Both cause light sensitivity. Both cause blurred vision. If you sit a patient with DED, and a patient with Sjogren's down side by side and ask them about their eyes, their answers will overlap almost completely. And here is where the system breaks down. When you go to an eye doctor, whether that's an ophthalmologist or an optometrist, they are expertly trained to evaluate and treat your eyes. That is their specialty. That is what they're supposed to do. They are not necessarily trained or positioned to screen for systemic autoimmune disease. So the typical patient journey looks like this. You develop persistent, dry, irritated eyes. You go to your eye doctor. They examine your eyes, confirm reduced tear production, and diagnose you with dry eye disease. You're given artificial tears, maybe a prescription for cyclosporine drops, perhaps punctal plugs to keep what tears you have from draining too fast. You go home. A few weeks pass. Maybe you feel slightly better, but then the symptoms creep back, or they never really improved. You return, they adjust your drops. The cycle repeats for months, sometimes years, and all the while, if the root cause is actually Sjogren's, the underlying autoimmune process is continuing. The immune system keeps attacking. Glandular tissue keeps being destroyed. And here is the part I need you to hear clearly. Sjogren's patients who go undiagnosed and untreated are at significantly elevated risk for complications that have nothing to do with their eyes. Peripheral neuropathy, kidney involvement, pulmonary complications, and, pause for a moment on this one, a 5 to 15 times higher risk of developing non-Hodgkin's lymphoma compared to the general population. 5 to 15 times higher. That is not a minor footnote. That is a reason to take this seriously right now. So how do you know if your dry eyes might actually be pointing to something bigger? This is where the systemic red flags come in. These are symptoms that dry eye disease simply does not cause. And if you have any combination of these alongside your dry eyes, your situation needs a completely different conversation with a different kind of doctor. Number 1, persistent dry mouth. Not just feeling thirsty. We're talking about difficulty swallowing food without water, difficulty speaking for long periods, waking up multiple times at night desperately needing water, a tongue that feels like sandpaper. Number 2, unexplained dental decay. Saliva is protective. It buffers acids, delivers minerals to your teeth, and fights bacteria. When the salivary glands are under autoimmune attack, teeth begin to decay rapidly, multiple cavities, crumbling enamel, sometimes tooth loss in people who brush regularly. Number 3, parotid gland swelling. That's the gland just in front of and below your ear. Sjogren's can cause recurring puffiness or tenderness there, sometimes making the cheek or jaw look swollen. Number 4, joint pain and swelling. Polyarthralgia, aching in multiple joints, is common in Sjogren's, often resembling the early stages of rheumatoid arthritis. Number 5, profound fatigue. And I want to be specific about what this fatigue feels like, because patients describe it consistently as bone-deep exhaustion, not the kind that resolves after a good night's sleep. The kind that follows you every single day and makes basic tasks feel enormous. Number 6, brain fog. Difficulty concentrating, memory slips, trouble finding words, a sense of cognitive cloudiness that is new and persistent. Number 7, skin and vaginal dryness. The dryness in Sjogren's is systemic, affecting mucosal surfaces throughout the body. Number 8, peripheral neuropathy. Tingling, numbness, or burning sensations in the hands and feet, signs that the nervous system is being affected. Number 9, Raynaud's phenomenon. This is when fingers or toes turn white or blue in response to cold or stress, because small blood vessels overconstrict. It's a classic autoimmune co-occurrence. Number 10, dry cough or breathing difficulties. The airways can also lose their normal moisture, leading to a persistent, dry, non-productive cough. Here is the rule I want you to remember. If you have dry eyes, plus 2 or more of those symptoms, you need to see a rheumatologist. Not just an eye doctor, a rheumatologist. I want to tell you about someone. Her name is Sarah. She's 47 years old, a middle school teacher, and she spent almost 2 full years in what I can only describe as a medical maze. Her eyes were constantly burning, gritty, and red. Her ophthalmologist diagnosed her with aqueous deficient dry eye and started her on Restasis. When that didn't fully help, they added punctal plugs. When she still struggled, they tried a different prescription. All reasonable responses to the diagnosis she had. But here's what no one was connecting. Sarah was exhausted every single day, the kind of tired that coffee didn't touch. She had 3 root canals in 1 year, despite being diligent about brushing and flossing. During cold snaps in winter, her fingers would go pale and numb, and she'd have to warm them under the tap before she could grade papers. She mentioned each of these things to different doctors over the years. Each one addressed their piece. Her dentist recommended fluoride treatments. Her GP suggested she was probably just overworked. No one was holding all the pieces at the same time. It took a new internist, someone who sat with her for a full intake appointment, and actually listened to ask a single question that changed everything. She asked, "Do you also have a dry mouth?" Sarah said yes. The internist referred her immediately to a rheumatologist. The blood work came back. Anti-SSA, Rho antibodies, positive. After a salivary gland biopsy confirmed the diagnosis, Sarah was told she had primary Sjogren's syndrome. She was started on hydroxychloroquine. She began a coordinated care plan involving her rheumatologist, ophthalmologist, and dentist working together. For the first time in nearly 2 years, she had a treatment plan that was actually addressing what was happening in her body. This story represents thousands of real patient experiences. Maybe it sounds familiar to you. Maybe it sounds like someone you love. In just a moment, I'll give you the exact 5 questions to take to your doctor, but first, you need to understand why the standard tests doctors run will completely miss Sjogren's if no one is specifically looking for it. Let's talk about what a proper diagnostic workup for Sjogren's actually looks like. The Schirmer's test is often the first step. A small strip of paper is placed under your lower eyelid to measure how many millimeters of tears are produced in 5 minutes. Less than 5 millimeters is considered abnormal. This test is useful, but it cannot tell you why your tear production is low. It has no ability to distinguish between a gland that is mechanically blocked and a gland that is being destroyed by your own immune system. Ocular surface staining with lissamine green or rose Bengal dyes can reveal patterns of surface damage that suggest more significant glandular involvement. This gives an eye specialist clues that something systemic may be at play. The critical step that moves you toward a Sjogren's diagnosis is blood testing. The most important markers are anti-SSA, also called anti-Rho, and anti-SSB, also called anti-La antibodies. These autoantibodies are present in approximately 70% of Sjogren's patients. A negative result does not rule out the disease, but a positive result is a significant diagnostic signal. Additional blood tests include ANA anti-nuclear antibody, which is broadly elevated in many autoimmune conditions, as well as ESR, CRP, and a complete blood count to look for anemia or white blood cell changes. The gold standard diagnostic procedure is a minor salivary gland biopsy. A small incision is made inside the lower lip, and tiny glandular tissue is removed and examined under a microscope. Pathologists look for a very specific finding called focal lymphocytic sialadenitis, clusters of immune cells, called lymphocytes infiltrating and damaging glandular tissue. This is the definitive confirmation. The 2016 ACR and EULR classification criteria give each diagnostic finding a point score. Positive lip biopsy, 3 points. Positive anti-SSA, Rho antibodies, 3 points. Abnormal ocular staining, 1 point. Abnormal Schirmer's, 1 point. Reduced salivary flow, 1 point. A total score of 4 or more points meets the classification threshold for Sjogren's syndrome. The critical takeaway here: none of these definitive tests happen in an eye clinic. Diagnosis requires rheumatologist involvement. Now let's talk about why getting the diagnosis right changes everything in terms of treatment. Because the treatment approaches for these two conditions diverge significantly, and treating Sjogren's as if it were just dry eye disease is, without exaggeration, like putting a bandage on a broken bone. For standard dry eye disease, treatments are focused on the eye surface itself. over-the-counter artificial tears, particularly preservative-free formulations used throughout the day. Omega-3 fatty acid supplements to support the oil component of the tear film. Warm compresses and lid hygiene to unclog meibomian glands. Prescription cyclosporine eye drops brand names Restasis and Sequa to reduce inflammation on the eye surface. Lifitegrast drops, brand name Shidra, which block a specific inflammatory pathway. Punctal plugs to reduce tear drainage. And in some cases, intense pulsed light therapy to improve meibomian gland function. These are all legitimate, evidence-based treatments. For dry eye disease, they make sense. For Sjogren's syndrome, they address exactly one symptom of a multi-organ disease. A Sjogren's treatment plan looks completely different. Hydroxychloroquine brand name Plaquenil is the cornerstone medication. It is a disease-modifying anti-malarial drug that broadly calms immune system overactivity. It has been shown to reduce fatigue, joint pain, and glandular inflammation in Sjogren's patients, and may reduce long-term lymphoma risk. Pilocarpine and Sevimline are cholinergic drugs that stimulate glandular tissue to produce more saliva and tears. NSAIDs help manage joint pain and inflammation. For patients with organ involvement, kidney, lung, or nervous system corticosteroids and immunosuppressants like methotrexate or mycophenolate may be needed. For severe or refractory cases, the biological agent rituximab, which targets B cells, the immune cells most implicated in Sjogren's, may be used. Sjogren's patients also need regular monitoring. Blood work every 6 to 12 months, regular lymphoma surveillance, and coordination across multiple specialties. The difference in these two treatment lists is not subtle. It is enormous. And every month a Sjogren's patient spends only on eye drops is a month the autoimmune process continues unchecked. Okay, now I want to give you something concrete and actionable. Here are the 5 questions to take to your next doctor's appointment. Pause the video right now and screenshot this list. Question 1. I have dry eyes. Have I been screened for Sjogren's syndrome? This forces your doctor to address the question directly, rather than staying in the DED management lane. Question 2. Can we run an anti-SSA, Rho and anti-SSB, lay antibody test